Excellent. So we have a busy agenda today. We have a presentation by our very own Chun-Li Chi about health system financing, which we're really looking forward to. Then we're gonna have our committee updates. In addition to an executive director report, and then finally some discussion about budget and strategy at the end. So before we begin, I'll pass it over to Judy to review any public comment we've received.
Thank you. We've received several public comments. Thank you to everyone who has been following our work, and especially to those of you who have written in. We've received several comments of support from Samantha Schmidt, Victoria Fisk, Elliot Page, and several students. So thank you for your thoughtful comments. Vern Sabri, Sable, sorry, from Oregon Chiropractic Association wrote regarding request for consideration of parity and non-discrimination in chiropractic services. And Bruce Thompson wrote about several elements for consideration regarding universal health plan design with references. So those have become part of the public record. Thank you again for sharing your thoughts.
Great. And now we'll pass it to Jenny, our interim executive director, for her report.
Thanks, Helen. So I have an update on our contracting, and then I'll give an update also on the executive director hiring. So in contracting, our UHP services contract, which was our largest procurement, closed on February 7th. We received 2 bids for that contract. One could not move forward. So we are looking at the bid that is eligible and reviewing it. No award has been made yet, but just to give you an idea of the process, if we decide that we will move forward with this contractor, there is a 7-day protest period after we decide that we're awarding for anyone to comment on the contracting process. And then we go through contract negotiations. My hope is that if we do move forward with this one bid that we received, we should be able to have the contract finalized in probably early to mid-April.
Can you remind us scope of work for this contract and also what's outstanding in terms of contracts?
Sure. The scope of work for this contract, this one includes support to all committees, operations, not community service, community engagement, communications, but for plan design, policy assistance, operations, policy assistance, financial assistance, and actuarial modeling. They'll also do the economic modeling for impact on the state of Oregon. The other contract that I want to update you on is the financial services contract, which was the smaller contract that was pulled out of the larger RFP. That one originally received no bids when it went out. So we went into an informal quote process. We received 1 quote, and we'll be moving forward with the bidder for that quote. That's Eco Northwest. They were announced as an intent to award yesterday. I think it actually posted today. And there's a 7-day co-bid process where it's posted on the Oregon co-bid site, and we have to see if anyone else wants to bid on it. Barring that, which I feel is unlikely, given that we didn't get a lot of interest on the contract originally, we will start contract negotiations with them after that 7-day period. Barring anything outside the scope of what would normally happen if there's a DOJ issue or there needs to be major changes to the contract, which we don't foresee, we would be able to contract with them likely by mid-March and have them on board.
Thanks.
In terms of the executive director hiring, an update for everyone. So 45 candidates were reviewed by the hiring committee. They were able to bring that down to 5 individuals that they wanted to interview. 1 individual did withdraw from the interview process, citing a different career opportunity they were excited about. So best of luck to them. And we will be starting interviews today and continuing the end of this week and through next week. And so on the schedule that was originally drawn up for hiring, we do have a tentative special session board meeting on March 4th that we can talk about whether or not we feel like that should move forward, but maybe after the interviews are conducted to make sure that the hiring committee does have candidates they want to move forward to the final interview.
So to clarify, we landed on 6 candidates to interview, and then 1 withdrew. So now we're left with 5.
So, thanks.
And I don't see anything on my calendar for March 4th, you said?
We haven't scheduled it yet because we want to make sure that there are individuals that they do want to move forward to a final interview round. And that was tentative when the original recruitment outline was drawn up.
Okay,
I think
So-
maybe a conversation needs to happen about whether or not there should be a special.
yeah, I don't know if I should be holding it and I don't know the time to hold.
Yes, so, so this is something that we can talk a little bit about. The idea would be if we wanted to have a special session of the board. The board wanted to interview our final candidates, to be part of that second interview, so that all of you would get a chance to meet the top two, three, one, two, three, candidates, however many we narrow down to. And so, the option would be to have a special meeting on the fourth, or to wait until our regular board meeting, which would be March 20th. The only reason to do the special session would be to speed the process along in terms of getting somebody on board and up and running, which I'm in favor of, but it would require.
I just would like to be able to hold the time,
Right,
otherwise I won't be available.
right,
We
and
can always cancel it.
you're not available. Okay,
Yeah, so.
what
if we
day of the
have-
week is March 4th?
It's a
March,
I thought it was a Thursday, but now I'm second guessing myself. It's either
Tuesday.
Tuesday or.
it's Tuesday.
It's Tuesday. Okay,
Yeah, my entire.
I'm not sure why we picked that day. I thought we would be on the Thursday
On a
as well, because
Thursday.
that's the day that most folks are available.
So I
Sounds like
think
it's-
what we can do is take a look at everybody's calendars and get some availability and see when there is availability for what would be a special
In
session
early March.
sometime in early March.
Right, and if we can't find a time when the majority of folks are available, then we'll just delay it till our March board meeting.
And it would be a virtual session.
Yes. we need to-
And I do want to also say that in terms of the hiring, as we're moving through the executive director hiring process, we did bring on a new policy analyst to help support staff with the work. And that policy analyst is here today. I'd like to introduce everyone to Kim Yee, who will be with us until we complete the executive director hiring process and can transition back to having a full team. So Kim is coming to us from OHA and has an immense policy background in healthcare and health policy and health insurance. And so I recommend everyone, if you have a chance at the break or after the meeting, an opportunity to introduce yourselves to Kim. Do you want to come up and introduce yourself?
We don't bite, come on.
Okay, and that's all I have for you.
Okay, great. So yeah, so just to clarify, we're excited about bringing these new contractors on. We had hoped at the beginning to just have one single sort of general contractor that would support all of our committees, and then we decided to pull out the revenue consulting component to support our finance committee. And so we're hoping that Eco Northwest as our revenue consultants will be up and running quickly within the next couple of weeks, and then there's still quite a long process involved in negotiating a contract with our larger contracting firm and deciding on them. So that likely wouldn't be in place till April, probably at the earliest. Yes, Jen.
I just wanted to thank you, Jenny, for stepping up and filling in. You've been immensely helpful and supportive to me on the Finance and Revenue Committee. And of course, I value you too, Katie. You've been great. So I just want to say that. Thank you.
Yeah. Yeah, thanks, Jen. And I inadvertently skipped over one agenda item. We need to approve the minutes from our January meeting. Is there a motion to approve January's meeting minutes?
So moved.
Second, right? Okay, great. And a vote?
Okay, Helen Malaka,
Yes.
Chad Chi,
Yes.
Debbie Diaz,
Should I abstain since I was not present? I did watch the recording, but I wasn't there.
Kate is fine. Amy Fellows,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg,
Yes.
Judy Richardson,
Yes.
and Cheryl Ramirez.
Yes.
Thank you.
Okay, great. At this point, I will turn it over to Chunway for his presentation.
Good morning, everyone. It is my pleasure to share with you something I feel passionate about, part of my expertise, and I also so happen to teach a course with a similar title this term. So the purpose for this short presentation is to give the committee, the board member, a kind of crash course on public on health system finance, particularly when we are looking at the universal healthcare, is a public finance. So I have 3 sections to share with you, and a very short first section is to talk about the nature of health system finance. And then I will move to focus more. So the second section will be the main focus for today's presentation, the public finance. And then lastly, briefly talk about how in assessing financial burden of healthcare, what are the common methods we use? Next. So let's start with the nature of health system finance. So one of my intellectual mentor, Bob Evans, who retired from UBC, in his classic work, Strength and Mercy, that has been considered probably one of the best textbook in health economics. He succinctly summarized the 3 key questions about health system finance. And if you ever have opportunity to listen to his talk, he's a very dynamic speaker and also humorous. Particularly, he likes to do wordplay. So this is one of his wordplay. And when he speak very fast in a funny way. That the 3 basic question is who pays, who gets paid. So on the who pays is about financing, how we collect our revenue. And again, in universal healthcare, it's about taxation, which in the second section, I will talk about that. But health system financing is not just concerned about who pays, but also concerned about who gets. Who gets is, actually, we have committee on that, it's about benefit design and who are eligible. And the other part of the important equation is who gets paid. That's the reimbursement system or payment system. So in the general principle of finance, the revenue generation of finance, the narrower sense of finance is about revenue generation, but broader sense of finance actually include both sides. In other words, finance and expenditure are often considered 2 sides of the same coin, because how much money we have to raise is totally depending on how much money we have to spend. And that's why in health system finance, we cannot consider the finance or the revenue generation alone. The 2 have to be compared simultaneously. And the second part, expenditure, is highly related to who gets paid. And the question is actually, the essence of the question is broader than who gets paid, but also how. How we pay them, the method, but also how much we pay them. So the second question and third question, together, they consider the expenditure side. And the first question is focusing on the revenue generation side. Next. So more specifically, the nature of health system finance examining about the sources where we generate funding. And then the contribution mechanism, how we generate, through what kind of mechanism, particularly what kind of tax. And then the third question is collecting agencies, through what agency we collect those revenue. And the last one is final destination of fund, how we use those funds in what services are paid to whom. And those terminology are an international standard terminology developed in the late 1980s and continue to revise. And that standard terminology is under the scheme called National Health Account. And United States was one of the pioneer in developing this standardization of terminology. And so the National Health Account serve multiple purposes, but one of the probably not the primary purpose, but still important purpose of National House account of standardizing terminology is very similar with the ICD code that standardize the name and the definition diagnosis of disease. And in the same manner, the National Health Account standardize the terminology. So when we compare other countries' finance, if they use the NHA standard terminology, then we know we are comparing the exactly same thing. Otherwise, oftentimes, what is considered out of pocket, what is considered private insurance may not be the same if they didn't follow the NHA standard. Next. And this next slide is a summary from my advisor's Bill Shaw's one of his article talking about why it is important to understand, to study health system finance. And I highlighted in the rate fund is the risk pooling part that's very important. And also it affects how we distribute the cost burden across the population. Also, it places the financial decision-making power in whatever particular organization we choose to make that decision. And then it also determines the resource allocation and distribution of service. That's what Evan talked about, who gets and who gets paid. And also the who gets paid on the last point, determine payment method. Next. So that's a quick overview of health system finance. In this next section, I will dive into public finance. And so this is a condensed of a 5-semester hour course into just roughly 15 or 20 minutes. Next. So let's start with talking about rationale for state involvement in health system finance. In a free market system like ours, one of the rationale is market failure. Market failure didn't mean market completely failed. In the economic sense, market failure generally indicate the market, the way it functions is not optimal. And the optimal is a normative sense, depending on how society want to define what is optimal. And of course, the neoclassic economists have their own definition, but generally we like to take the societal point of view. For example, either it leaves out too many people and ensure or make healthcare unaffordable, etc. And then the second important point is externality. It means one person or one organization's action has external effect. And there's also public's interest in private health, particularly in the there are different philosophical arguments. One of the simplest related to externality is about contagion, infectious diseases. So there's public interest in private health. Some people may not know, in the United States, despite we haven't had a countrywide universal health care, but we do have at least one disease that's universal health care. That's tuberculosis. So anyone who diagnosed with tuberculosis are subject to mandatory treatment, quarantine, and the treatment is free because it's mandatory. So that's the only disease so far we have universal health care. And then the end-stage renal failure is close to, but not complete. So this is an example. But then there are the third point, human capital. That is, society are interested in maintaining a productive labor force. And to contribute to productive labor force, two essential social services are required: healthcare and education. And this is why across almost all countries, there are different levels of public finance on education and on healthcare. The fourth one is merit good. Merit good is a classification of goods following the, I will explain a bit more detail following the public finance scheme. And I will come back to explain the merit good. And then there's a philosophical and ethical argument, healthcare as a basic right. And the last one is seldom invoked. This one was introduced by, again, one of my intellectual mentor, Professor Gavin. He was the first health economist to introduce this notion, arguing health system should not be treated merely as an industry. It's broader than just an industry. He argued it should be treated as a social institution, and there's a very different implication. Next, please. So let's look at what are the social function of public health system finance. Promoting health, arguably the private finance can contribute to some degree, but it can never match with what public system can achieve. And also, equitable financial burden, that's the one the private finance cannot achieve, only public finance can achieve. Similarly, equitable access to healthcare, also only public finance can achieve. And the fourth
John,
one,
can
yes.
you explain what equitable financial burden means? Because you could interpret that in a variety of ways.
Yes, that's what I will discuss in detail on the third section
Okay,
on equity. So yes, it's normative. So there are different distributive justice principles to decide what is considered equitable. But let me just quickly mention, despite the equity of financial burden is being very normative, amazingly, if you look at across the world, for most countries, there's an amazing consensus. The general consensus in terms of equitable financial burden in healthcare is ability to pay principle. The ability to pay principle has near universal consensus. The difference is how progressive you want to structure you based on ability to pay. To put it in simple English, ability to pay means people who are able to pay more. So that's the general principle. But then within that principle, there's a still wide range how progressive you want to structure that. And equitable access to healthcare is also normative, but it's the distributive justice principle is more complicated than a simple ability to pay can gain consensus. The fourth point, income redistribution. The private insurance has achieved a portion of that. Because even in private health insurance, is the healthy subsidize the unhealthy within that pool. So that income redistribution is narrow within the same pool. But only the universal healthcare system through public finance, that income redistribution is comprehensive and complete across the population. And it also add one dimension that private health insurance cannot achieve. The income redistribution in private health insurance is people who are healthy, subsidized or support unhealthy. But in public finance system, they also achieve healthy, subsidized or support unhealthy. In addition, it also achieve high income, subsidized, low income. And that part, the private finance cannot achieve. And human capital, I mentioned about before, that's public-private finance all want to achieve the human capital, meaning maintaining a healthy, productive workforce. The last one, again, is seldom being brought up. It was brought up by my mentor, Gavin Mooney, as he talked about health system should be treated as a social institution. And this is one of the rationale, because health system, when we treated that as a social institution, it indicates what kind of society we want. And that should be reflected to what kind of health system we want to establish. And that's why he called that an important function of a public finance health system is how that can help us achieve a better society. Next. And in the public finance literature, I give my reference on the top by Musgrave, and Musgrave considered the founding father of the public finance system. They argue is the communal interest give rise to communal wants. And then they are generated by and pertain to the welfare of the group as a whole. The group usually can be a community or the whole society, whole country. Next. So public system, because of those communal wants, public system can embody public redistribution of policy in a way that private insurance cannot, which I mentioned earlier. Also, public insurance serves as a collective purchasing agency for consumer or patients. And using Governor Mooney's term for residents or citizens rather than using the term consumer and patient. Next. So when we look at the source of government revenue, that's a key for public finance. We are all familiar with tax, and then there's a fees. In the in the recent, I think it was Tuesday, this Tuesday's finance committee, one member talked about whether we want to collect a premium. And I mentioned premium belong to fees. And in the context of public finance, any fee or whatever name you name it, including traffic fine, anything, it doesn't matter the name, as long as it's mandatory, it's tax. It's one of the tax. We can call it whatever name we name it, fee, fine, premium, but anything that's mandatory is tax. That in the public finance analysis, they should be treated as such as tax, and that's related to tax burden and tax equity. And in the US, we don't have significant public sector enterprise surplus. For example, Norway, oil and natural gas producing country, they have a lot of the public sector enterprise surplus. And so government has that extra revenue to supplement or sometimes replace some of the taxes they can use in many social functions. Foreign aid usually is for middle low income countries. Borrowing, it happened across high middle low income countries. And the last one is money creation. That's the last resort for government to generate revenue. And US did that during Vietnam War and therefore abolish the gold standard. So we have this term gold standard, it has a significance in the currency and monetary policy. Prior to around 1971, that's during the Vietnam War, every country, when they want to create money, they have to decide for each unit of the currency, whether it's mark, pound, dollar, for each dollar, each pound, how much gold that worth. And government has to have equivalent of the amount of gold before they can print money. So whatever amount of the money is in circulation, the government has to have equivalent gold as a guarantee. But during Vietnam War, US need to generate more money than the US gold reserve have. So US was the first one to abandon the gold standard. And every country follow. And when gold standard is abandoned, the exchange rate started to grow because it like a stock, because it's not backed by the gold. Before that, the exchange rate is nearly, except for there's a super inflation, they're nearly fixed. So every country's currency, their exchange rate are fixed because the gold is fixed, but that's all changed. So that's just a bit history. So money creation is the last resort for government to generate revenue. Next. And in terms of public finance of national health system, one common source is general tax revenue, such as UK. And country like Canada, they use combined, and Taiwan also use combined. But UK use almost exclusively general tax revenue. The second common source is earmarked tax, such as payroll tax. So in the finance committee, we're considering both the general tax as well as earmarked tax. And then there are various types of special tax, such as gasoline tax, tobacco tax, etc. Next. And public subsidy is an important issue in public finance, because for the rest of the finance is generate revenue, except this one, public subsidy, is actually an expenditure. And in the public finance literature, they have specific term called tax expenditure. And this concept is very important to bear in mind. For example, in the US, we subsidize private health insurance. The latest, I couldn't find much later, the most later is estimated on 2023. So it was $1.3 trillion. Why we have this tax expenditure? Because this is what employer pay for employee insurance as part of their compensation income. And that technically should be taxed as income. But we decided long time ago to exempt that, to encourage people to have private health insurance. And so that part will not tax on the employee side or employer side, because employer take that as exempt from their revenue or profit. So that part of the tax is lost. So the revenue we could have collected, but we decided not to collect, is called tax expenditure. They should be treated mathematically like we spent the money, because these are the money we could have collected. And so this has been a very contentious issue for decades, because the tax expenditure in private health insurance benefit more for the high income people, particularly high salary people. The ACA modified that, because the ACA capped the tax-free health benefit at around $20,000 to $24,000. That under that, you're still tax-free. But if you get more general coverage of private health insurance worth more than that figure, that amount will be taxed as your income. So the ACA partially addressed that issue. And then there's a fees, public enterprise surplus not applicable to us, loan and foreign aid not applicable to us. Next. So let me briefly talk about the nature of goods. Musgrave and Musgrave, they classify all goods into three categories. The primary goods, that cover most of the goods services we encounter. And the three major characteristics is rival consumption, meaning one person's consumption exclude another person's consumption. And the second is excludability, meaning you can exclude non-payer. There's no free ride on consumption. And the last one is no externality. One person's consumption or production does not generate external effect. Next. So most goods services belong to the first category. And that category in a free market society has very little debate about who should provide it. We generally let the free market to provide, with some constraint such as prevention of monopoly. But the second type of goods called merit goods. So the three characteristics: first, rival consumption, similar with private good. Second, excludability can prevent free rider, also the same as private good. the difference between merit good and private good is the third externality. The good service belong to merit good generate external effect. So goods in this category are subject to most policy debate. Because the first category, there's a little debate that the free market can allocate it properly. And the reason this category very good subject to big debate is, on the one hand, the free market can distribute it, but the debate is on the third one, externality. The goods belong to very good. Two classic examples are healthcare and education. Both have huge externality. If we entirely leave it to market, the market can distribute them, except the results are generally not desirable by most people in the society. Because then the low-income people will not get education, the low-income people will not get healthcare if you leave it completely to free market. And of course, in the US, there are constantly this force want to highly privatize our education and healthcare. And that's why hence the debate, because it is feasible to be allocated by the free market. The question is whether it's desired. Next. The last category, public goods, again, is not less subject to debate. The three characteristics, one is non-rival consumption, meaning one person's consumption does not exclude other people's consumption. And second, non-excludability, meaning you cannot prevent free riders. And the third are the same as the merit good and the externality. And so, typical example, like government regulation on clean air. And technically, government can say, we want to charge everyone fee for this regulation of clean air. But if people decided they don't want to pay, the non-rival consumption and non-excludability makes that not feasible. Local security, safety, national defense, etc., all belong to here. And so because of this nature, the public goods also are less subject to debate, because generally only government can perform that function. So the core debate of how and to what extent society want to have public or private finance and delivery focus on the merit good, because it is feasible by market, but may not be desirable. Next. So this table, I summarize those key points about the three categories of goods, public, merit, and private. And in terms of the three characteristics, how they are different from each other. Next. And in the last 2 decades, we have observed internationally growing public share of health system finance. And these are among the core reasons: cost control, equity concern, and there are more integration of healthcare finance and health promotion. When government or public finance are involved, it makes the integration of public finance part, particularly insurance part, integrate more smoothly with the health promotion. And also recognition of the limit of market in healthcare. Next. So this shows the public versus private spending in healthcare in OECD country, the high-income groups. The red bars are the OECD average, and I circled the US on the far left. Next. So in terms of tax, there are direct taxes. So the direct taxes are those which impose initially on the individual or household, and that is intent for the individual or household to bear the burden. So example of direct tax like income tax and payroll tax. And indirect tax impose a certain action, but the party, individual or organization, agency who initially paid that tax may not bear the final burden. This is why they are called indirect, because those burdens can be shifted to the final user, such as sales tax, excise tax, and value-added tax. Next. And transfer payment is considered negative tax. So for example, social security and various type of subsidies. Next. And let me just very briefly talk about personal income tax. The complication of personal income tax is deduction. And the reason for deduction is for equity, because two persons making the exactly same amount of income, if you tax them the same amount, it doesn't mean they bear the same level of burden, because one person might be single, the other person might have a family of 4 or 5, and that person is the only income generators. And so even though the two persons making the exact same income, their burden is not the same. So this is just one example of why. And the deduction makes any tax system very complicated. So there's always constant debate weighing equity versus efficiency and tax burden. And so it's not easy to strike a balance on that. And the tax-free income are the exemption plus standardized or itemized deduction. And also there's a question about what we define as tax base. Next. I talk about the deductions. The concern is about equity, but also there are also incentive aspects. So the society or government may decide what kind of activity we want to encourage people to do. And if we want to encourage people to do such as improving health, then people's expenses on those activities government want to encourage. It's not just healthcare, but also education. We should allow them to deduct from the income tax base. So that's the incentive aspects. Next. Because of the complexity of general income tax, in the 1990s, one of the presidential election, one candidate actually proposed flat tax, make it simple. And this is an example of flat tax. The tax liability equals to the minus alpha. That the minus alpha is the positive number of dollars. That's standard deduction. So you, but you multiply your income with tax rate, and then you minus the standard deduction, then you have the tax liability. Next. Other taxes on consumption. Historically, only India, for a very brief time, tried expenditure tax, because the logic or philosophy in income tax is is complicated, but also doesn't consider expenditure. Where expenditure tax, one benefit is to encourage people saving if you don't want people to overspend. But expenditure tax is too complicated to implement. So India only implement very briefly, and no one else ever tried that. And then there's a sales tax or value-added tax. There are also special tax and excise tax. Excise tax are often levied in, for example, in gasoline, in tobacco, in many states actually have an excise tax on tire. The tire you replace, the price you pay includes that, and also hotel. And then there's payroll tax, property and estate tax. US and Canada are the only two high-income countries heavily rely on property tax generally for local revenue. And then there's an inheritance tax. Poll tax is very regressive. In modern time, only UK implemented briefly in the mid-1980s. That generate huge protest, even riot, because poll tax, that's a very ancient tax, that it taxes every person, irrespective of age, irrespective of your income, the exactly same amount. So if you have 5 members, including baby in the household, we pay 5 of that poll tax. And that's extremely regressive, but amazingly, UK in modern time is the only country tried to implement that very quickly because of the outrage and protest. They repeal that. Next. So the last section, I would like to briefly back to Bruce's question, how we assess equity and financial burden of healthcare. Next. So in the literature of public finance, they have two notions of financial equity. Originally, this was designed to assess tax burden. But health economists has applied the same notion to not just financial burden of healthcare, but they even apply the same notion to equity in access to healthcare. And so the notion of horizontal equity argue that people with the same wealth, same income should bear the same burden of taxes. So I use T1, T2, T3 that's representing the tax, ABC representing 3%. So if the 3%, Y represent income. So if the 3% have the same income, their tax should be the same. That's called horizontal equity. Next. The other notion, vertical equity, the idea is people who make more income should be a higher rate of tax. So this is very peculiar in the public finance literature, because in the normal sense, we might think vertical equity means people with high income pay more in absolute amount, pay more income, but that's not what public finance literature argues. Paying more income is not enough. So I have a table below, which shows that one person income 10,000, the other 20,000. And the person in 10,000 pays $1,000 tax. The person in $20,000 pays $3,000 tax. So the tax rate is different. And the rationale for a progressive tax is people who make more income generally have more disposable income. Everyone will need certain amount of money to sustain their own life, food, clothing, housing, etc., the basic. Above that, if your income above that, the more your income above that, you have more disposable income. So that's a very peculiar point. Public economists argue the progressive tax is people with higher income pay higher rate, not just higher amounts. Next, please. Within vertical equity, the proportional tax is people pay the same rate. So I have example here. A person 1 makes 10,000, person 2 makes 20,000. And the person 1's tax is 1,000, person 2's tax is 2,000. The tax rate is the same, 10%. So in the public finance literature, this is not considered progressive. Because in the normal sense, we might think this is progressive because people making high income pay more tax. But in the public finance literature, the progressive is measured not by nominal amount, but by rate. The argument is because high income people, they have more disposable income, more capable of doing that. So this is called proportional tax. Next. The regressive tax, including people, I have example here, the $10,000 income people and $20,000 people income pay exactly same amount of tax, but result in different rate. So this is considered regressive. So progressive, proportional, regressive is the more refined classification. But in general conversation, including policy debate, we often kind of skip the proportional one, but talk about how progressive or how regressive the tax is. And so those charts give you the sense of what progressive in the public finance means. It means not just pay more money, but more rate. Next. And tax incidence is an assessment of the final burden. So economists, they will analyze. I mentioned earlier, the indirect tax, when we levy, whether it's value added tax or sales tax, it's not the initial person entity who pays the tax via the burden. They get transferred. And the tax instance is the practice of assessing who bear the final burden of the tax. So that's an exercise economists perform to assess the tax equity. Next. And there are different tax instance. I will not get into detail. The economic instance asks the final burden. The statutory instance asks who pay tax. So the who pay tax may not be the person being the final burden. And the final burden distribution may differ from that of statutory liability. Next. And there are different distributive justice view of tax equity. I will not get into too much detail here. Endowment-based criteria, and then there's a utilitarian criteria, egalitarian, and or mixed criteria. And in addition to those commonly discussed in the textbook, there are also two generally discussed not under those categories. One I already mentioned, ability to pay. The other is is benefit-based. The benefit-based principle of taxation doesn't consider ability to pay, but consider who uses or who benefit from certain services. And the benefit principle are not very popular, not just in this country, but across the board. But we do have benefit principle taxation. For example, when you apply passport, you have to pay the fee, which is a tax. So that's based on benefit principles. So any services that government charge fee generally follow the benefit principle. And the free services generally follow the ability to pay principle. Next. So this look at the regressive nature of sales tax. And because of the time limit, I'm not going to get into detail, but you have the slide. You can look at how that sales tax is generally very regressive because it put a higher burden on the low-income people. Next. And since 1980s, OECD has conducted progressivity of healthcare finance using the so-called Equality Index. One of my former PhD students did that in her dissertation, and I sent an article and published it in a journal on the equity of financial burden in Chile. Next. And
Could you just talk for a minute about the difference between a sales tax and a value added? And particularly in regard to progressivity and regressivity?
both are regressive. Value added tax in the US, we don't have value added tax, but the Clinton administration in his 1994 proposal for healthcare reform, he proposed to use value added tax to finance his reform, try to achieve near universal healthcare. But of course, that didn't succeed. Value added tax, most European countries have that. It means at each level of value added, an example would be you have the roll height, and the height sent to the tanner, tan into the leather. So that's a value added. So the tanner have to pay tax on value added when the tanner sell that. So government charges that. And then say the shoemaker bought the leather from the tanner and use the leather made into shoe. And when the shoemaker wants to sell that shoe, it's value added. So that's another layer of tax. So depending on from the raw material to the final product, how many process of value added, each process government tax it. And of course, this is the classic example of indirect tax. the payer don't bear the burden. The tanner, the shoemaker, they pay tax, but they don't bear the burden. They just added the tax to the price. So it's the consumer, just like sales tax, the consumer bear the burden.
Is there a version of value-added tax in healthcare?
Not specific, because European country with universal healthcare, many of them finance through general tax. So the value added tax were part of the government revenue. So it's not just earmarked for healthcare, but
Where you could imagine different benefit levels.
President Clinton tried to do that.
That's what he was
exclusively-
doing with it.
Exclusive for
So you
healthcare.
get a higher level of benefits if you were willing to pay more tax? Is that how it would work?
No, consumers don't actually see that, because, for example, if you shop in Europe, you don't see how much value added tax you do, only if you meet the tax return, tax refund at the airport. They will give you tax refund. The refund amount generally is equivalent to the value added tax. But otherwise, if you don't get tax refund, you don't know how much of the value tax you pay, say in a purse, in a shoe, you don't know. Because it's all built into the price. So it has nothing to do with the quality of the goods. It's just a process, and each process government tax that value added. Does that
Thanks.
help? Yeah. So this is an example. My colleague in Taiwan, they have been tracking. So the health benefit versus tax burden of income quintile. So on the top is the lowest 20% income quintile in Taiwan. And this is assessing their tax burden. Taiwan called premium, but they are tax. The tax burden versus the actual healthcare they use in a given year. And they can calculate the money amount of that. So you can see it's relatively progressive. The lowest quintile on the top, their benefit to tax burden is close to 2. And then the highest income quintile, the top 20% income group, the curve at the bottom. So they pay more than the services they receive. So this is the example from Taiwan. Next. And once we implement that, we should track that as well to see how equitable is our both financial burden and healthcare access. So this is the summary of what constitutes a good tax structure. First condition is should be adequate for the purpose. And second is equitable distribution. And the third one is to complement the second one about tax instance, meaning the burden has to be assessed through tax instance, not who pays tax, it's who bears the burden. And fourth is minimize interference with economic decision. On Tuesday, I mentioned about Washington, our neighbor, is also developing tax, and we should reference that so it's not put all Oregonian too much expenditure affect our economy. Next. And the tax structure should facilitate use of fiscal policy. This is probably less concerned about health system finance, more concerned about general finance. And the number 6, permit fair and non-arbitrary administration. Non-arbitrary administration, the classic case was during Roman Empire. The Roman Empire would auction off their provincial or regional tax to the person who give the highest bid. And let's say one person bid using current money, one province for $20 million. That's the amount the person will commit to Roman Empire. But then that person can decide how much they want to tax, and they can tax 30, 40, $50 million. And this was why in the Roman Empire, taxpayers are so hated. And that related to arbitrary administration. And then the last one is administrative and compliance costs. That should be considered. This is often considered as tax efficiency, meaning for every dollar tax you collect, how much you have to spend in administration and compliance costs. The US IRS is highly efficient. For every, the last information I saw, for every dollar we collect, the cost, not just to the IS, but also we have to assess cost to the people, the taxpayer. The cost is less than, I remember, less than 5 cents for government to collect $1. So this is also something we have to consider when we consider the different tax. Next. And this is regarding cost sharing. One of my my mentor Evans talk about why cost sharing theoretically pronounced dead, intellectually pronounced dead, but they keep coming back. So he was famously called the people who asked to implement cost sharing are like zombies. So that's his zombie theories. And then he quoted originally was was from Hegel. What is rational is actual, and what is actual is rational. And Professor Marmer simplified that sentence to nothing that is regular is stupid, meaning why something intellectually dead, cost sharing keep coming back? Because it's not stupid, it's benefit someone who advocate that. Next. So I developed this chart specifically for today's presentation. I briefly touched on that. In the private finance, the income redistribution effect is from healthy to unhealthy, and that also achieved in public finance. Also, the income redistribution in private insurance goes from consumer to provider and investor. That also achieved in public finance. What private finance cannot achieve is the last one in green, from the high income to low income. Next. So that's all I have. Any comments or questions? Yes.
So first, I was going to ask you about value-added taxes too, because as you know, we're trying to do a deep dive on taxes and what we can all use for revenue. And your explanation made me remember that when I lived in Germany and bought certain goods, I could get a refund on the value-added tax because I wasn't a German citizen and didn't get any of the benefits. And I remember it being 14% at the time. This was in the early 80s. I don't know what it is now. But one question I had is, as you know, we're looking at a corporate income tax as a revenue source. So I wanted to understand what you meant on that slide, that only people can be taxed, not corporations. And maybe I misunderstood you, but we were looking at that as a revenue source. So could you explain that a bit?
Yes, that's the argument by public finance economists. The corporation tax, if we levy higher corporation tax, corporations are not person, even though our Supreme Court defines corporation as person. But from public economic and public finance, they're not person. Only real human are person. So corporations, if we levy higher tax, they have the capability in most cases to factor that into the production costs.
Okay.
So they have the ability to shift the tax burden to others. And that's why instead, it's not that we shouldn't tax corporation, because if certain product, we don't want the society to be overconsumed. That's the rationale to tax certain industry corporations. But if you want the tax burden to be fair, we should have a more progressive tax rate on the high income, because the profit of the corporation distributed to individual. So it's the individual.
Right.
If the corporation make lots of money, the money eventually distribute to individuals. So it's the individual we should tax. And that tax on the individual cannot be transferred to others. They bear the actual burden. Yes.
Charlie, talk a little bit about, and you didn't mention this, but about luxury taxes and how they fit into the picture.
Yes, luxury tax, again, the society, whether it's federal or state government, can decide whether we want to, there are two rationale. One is they will cases in countries, they don't want people to overconsume luxury item. And the luxury item is highly arbitrary.
Right.
Okay. So that's one rationale. You want to limit the consumption of whatever defined as luxury item. The other rationale, probably more common, is the assumption that people who are able to consume luxury items are higher income. So if there are barriers to increase the tax rate on high income, this is the subtle way to tax the high income, assuming. But then again, you have to be careful defining what are luxury items. Make sure we are taxing the right people. The right people meaning people who are very high income. So we tax them.
Thanks, very helpful.
I mean, I was really interested in your description of private goods, merit goods, and public goods. And I think this is where we get tied up a little bit in this discussion is coming to agreement on whether healthcare is a merit good or a public good. In some cases, would argue that it's even a private good, right?
But again, the classification and the definition came from Musgrave and Musgrave. And they have very clear definition of what counts or what considered private, what considered merit, what considered public. And I have laid out those important conditions. And I know in the common usage of the language, most people didn't learn public economics, so they don't distinguish the difference between merit good and public good. So the key distinction is the merit good is possible to be allocated by the market, but the question is the result of market allocation generally are not desirable. Education, healthcare, and there are others. So a few others belong to merit good, public park. We can charge park because it's feasible to exclude non-payers. But we want people to enjoy open spaces that's good for people's physical and mental health. If the society think that's desirable, then park should be free. So whether we charge park admission fee or not has to do with how much society view. Similarly, library. There are private libraries that you have to pay membership fee to use, but most cities have public library free. And public libraries serve the same function as education. Firefighting. When I teach this course, I use this as an example. Firefighting started in this country as a private enterprise in the late 1600s. At that time, it worked for a while because at that time, most people, immigrants in this country were in New England, and there were still fewer of them. So most people live in independent house. So if your house are on fire, you call the company to put out the fire, pay the fee. If you cannot afford to pay the fee, they don't come. But this, by early 18th century, when more immigrants came, most people no longer, particularly in the city, no longer live in an independent house. They live in the row houses. Some of them you can still see them in Boston. Usually 3-story, long row, similar with European houses. Now, if you live in one of those row houses and unit, your unit is on fire, but you cannot afford to call the for-profit firefighting services. The fire didn't start in your unit. So it didn't take long for the early immigrants to realize it's a bad idea to have firefighting as a private good. So they make that into technically firefighting is actually beyond public good. Because when you, particularly in an apartment or row house situation, if you put out one unit, it has external effect. All the other units got protected. So firefighting is a good example of public good.
It's interesting though, because with some of those examples with parks and libraries and firefighting, people don't tend to overuse those, which is different in healthcare. If you make healthcare a public good, you have the problem of overutilization, which can actually take away, right? The externality goes the other way, that one person their overutilization can limit access or availability for other people.
That's a good point. I was going to comment on that. I mentioned about tax burden, two popular burden principle. One is ability to pay, people who are able to pay more. The other is benefit principle. And this is the subtle area we need to consider on the benefit package. That what service in our universal health care, we think they are important for everyone. Therefore, we should not charge cost sharing. But there will be some services. And again, no country can cover unlimited services. There will be some services that we don't think essential for everyone. We may consider apply benefit principle that either charge fee or cost sharing. The non-essential part. So that's very complicated, something we can consider. Yes, Amy.
On Helen's overutilization comment, I was wondering, how do the countries with universal health care handle the concern about overutilization, or is that more of a transition concern? If that makes sense?
Well, overutilization, again, is a complex issue. Health economists, particularly those mainstream health economists following the neoclassic school, have a very peculiar definition of overutilization. And that's why the mainstream health economists always recommend cost sharing. Because their assessment of overutilization has nothing to do with your health need or whether the health care you use is effective or appropriate. These are irrelevant. The only criteria they assess, which they appear in many papers published and often used as the foundation for policy. The only criteria to decide to assess whether one's use of healthcare is overuse or appropriate use is your willingness to pay versus market price. So Professor Reinhardt gave this example. Let's say a postnatal care, the social cost, they assess the social cost based on an assumption the market is competitive, which open question, but let's take a step back, say market is competitive. So when the market is competitive, the social cost of any goods and service is the market price. So let's say the market price for postnatal care is $100 per visit. And I should have bring that curve. People have different demand curve. The demand curve is based on your willingness to pay. And the economy assume, just like a roll of bread, that when you are hungry, the first roll of bread was a lot to you. But after you have the first roll of bread, the second roll of bread was less and continue to decline. And that's in economic jargon called declining marginal benefit. And the declining marginal benefit will reflect in declining demand, meaning the first visit you use value most. The second visit you use value less. So that's how they mark the demand curve. So using that postnatal care, $100 social cost as an example. He used Smith and Chen, two family. The Smith family are poor, so their willingness to pay up to the third visit will be $80. But the Chen family is wealthy. Their willingness to pay up to the 8th visit is $80, below the social cost $100. So the poor family, they're willing to pay above $100 is up to second visit. After second visit, they're willing to pay drop. But Smith family, the Chen family, wealthy, up to 8th visit, the 9th visit below. So for the Smith family, if that's universal health care, their third visit and fourth visit will be overused. Why? Because their willingness to pay below the social costs. So economists even have this jargon called welfare loss. So for the Smith family, their third visit willingness to pay is $80, but costs society $100. So their third visit, society lost $20. That's a social welfare cost.
So,
yes.
so whether Mrs. Smith had postnatal depression
Irrelevant,
or me,
totally
is
irrelevant. Totally irrelevant. Health condition or effectiveness of healthcare are irrelevant. The only relevant information is willingness to pay.
Yeah, but hold on, there's another way to deal with overutilization that isn't around finance.
Exactly, yes.
And I
Yes.
think finance is perhaps one tool, maybe not a good tool, but there's other tools
I
about
fully
that.
agree, yeah,
With such, and that a lot of overutilization isn't simply consumer driven. It's actually provider
exactly.
driven as well. And so different forms of utilization review and other ways of dealing with overutilization, I think are appropriate and perhaps more appropriate than using economic tools, which haven't been very effective.
I fully agree with you. I have been fighting against this new classic economic argument for 2 decades. Ever since Taiwan implemented universal healthcare. Every few years, economists and providers want to increase the cost sharing. The argument is overuse.
Well, and how do you define overutilization? Number one, you look at the Dartmouth Atlas and we have wildly divergent patterns in utilization. And some will all tell you our utilization is appropriate. It's yours that's not.
Yeah.
And it's often driven by providers of care, not by consumers. So when you put the economic burden on consumers, it doesn't work as well because they're not driving.
Yeah, exactly. Besides the so-called supply-induced demand, a simple logic conversation to refute whatever is called zombie argument for cost sharing. The zombie argument also comes from the new classic economists. It's asking, let's say if we increase the cost sharing from $20 to $50, then we can reduce overuse. Whose overuse will be reduced? Increasing from 20 to 50, will that affect person who is making $300,000 a year? Or affecting person who is making $30,000?
We actually studied this in Oregon back in the early 2000s when we had copays. And we actually showed how it was different amongst different economic levels, mostly around low-income populations, but it was pretty clear that, copays and co-insurance actually had more of effect in having people not get needed care in lower incomes, and that upper income individuals were able to afford it. So we've got some pretty good data that shows they really don't provide the effect that we think they do.
Yeah, the ethical argument against the neoclassic notion of welfare loss is based on their notion, the same healthcare used by the low-income people is overused, but used by the wealthy people is not overused.
Exactly.
That's the problematic ethic.
Debbie, do you have a question? And then we'll take a break.
Judy.
Thank you. I actually had just a quick comment back to Bruce's comment on provider-driven overutilization. I knew a neurologist once who said if they had a X amount of time, I forget if it was an hour and a half or so, to assess patients coming in with stroke-like symptoms after the fact of getting a CT and initially ruling out a hemorrhage, that they could avoid, if they had enough time to do a full assessment and history, they could probably avoid a percentage of the MRIs they ordered. But because they have such a fixed amount of time and are unable to do that, they end up over ordering MRIs that otherwise they may not need to. And I imagine that concept translates across specialties. And I know I've contended with that personally. So just wanted to add that.
I just wanted to underscore Bruce's point, and one of the things that Toy did mention about market failures and health economics is information asymmetry as well. And so you're speaking to this, we do have tools as clinicians, like the Choosing Wisely campaign that's been well established based on the Dartmouth Atlas, that can help us when we have knowledge that a consumer doesn't have, to judiciously make recommendations and not overuse just this.
Yeah. I fully agree with Debbie though, because like, as you know, the access is a problem, and when you have really high demand on a system and a lot of people trying to get care, then the tendency is you can make the visit a lot shorter just by ordering a whole lot of tests, right? And so, yeah, that's something, we have competing priorities there.
Yeah, and eventually, I think it's up to this board to carefully to assess and establish a criteria, what is appropriate use of healthcare. And the subject of appropriate use of healthcare was introduced in the academic world in the 1980s, but then quickly dropped because of the influence of neoclassic, because they think they figure out based on willingness to pay. But I think we need to revisit that. What is appropriate use of healthcare? And that will help us to design a policy as well as finance to minimize the unnecessary use of healthcare. The unnecessary has to do with healthcare needs as well as effectiveness of the or appropriate use of that particular technology or healthcare.
Any other final comments? Go ahead, Michelle.
Thank you. I don't want to delay the break, but so maybe we can, if we can't address this here, I could follow up via email with you, Dr. G, but I was wondering if there's a precedent for systems that include eligibility structured to respond to pent-up demand due to the high cost of healthcare for an interim period of time, and then phase that out to a more generous plan once pent-up demand has theoretically been handled or at least ameliorated? Is that a model that exists?
We briefly touched on this issue that we will need to discuss in detail in the finance committee, but also the whole board. Is in terms of how the system responds to unusual demand. Most countries' universal healthcare system by law are required to have a reserve. And on Tuesday, I give the example of Taiwan. Taiwan's system by law required to have between 1 to 3 months expenditure as a reserve. These are not to be spent as a reserve. And then he also specified if the reserve accumulated to more than 3 months, then government should consider lower the tax. If the reserve is below 1 month, government should raise the tax. So that's something for us to consider.
And we've got a fair amount of experience having dealt with pent-up demand here in this state several times when we expanded access to care, when we decreased access to care and then reinstated it. And so actually, when you speak to a lot of the actuaries and others, we've got some pretty good data and information to be able to talk about just exactly how much that is. And it's one time.
Great. Well, thank you so much, Sean. We really appreciate that. That was excellent. We're going to take a break now and we can reconvene at 10:35.
Thanks, Chen Wei. That's great.
Whenever you're ready.
Great, welcome back, everyone. So the next part of our agenda is the committee updates. I'm going to be turning it over to our committee chairs for their updates, including any straw proposals, if there are any, and we can have a discussion about that. So we'll start with community engagement and communications. Michelle Haney. Michelle's gonna take the lead, I think.
Thank you, Chair. Good afternoon, everyone. Fred would like to help share this update with you all. So the Community Engagement and Communications Committee, since we last spoke with you, the updates are that we've paused our contract with Artemis Consulting at the suggestion of Diana Bianca, who you all heard from last time. And this is directly in response to the updated information on timeline that we received from the other committees, and the nature of the responsive work that this contract was designed to do, facilitating targeted community engagement to solicit feedback on the draft plan design. And so she has paused her contract, planning to come back in April to start working on question design to be ready by the anticipated June-ish plan that's ready to be taken out for community engagement and feedback collection. She did write a really thoughtful memo that we will share with all of you, to Amy and myself, the co-chairs of the committee, and also to Chair Blanca. So, that's one update. In that frees the committee up to pivot to our second focus area. We've been really focused on community engagement and gearing up for that work stream. And this now frees us up to do some proactive work on communication, which I think will be helpful, especially as we return to question design with the committee and then with all of you. So we are working on lining up presenters, and we have one at our February community engagement meeting on the 26th, next Wednesday. Patty Wentz is a strategic communications expert in healthcare communications specifically, and is going to prepare the committee to think strategically about how we can frame questions and the work of the board in a strategic way so that we can shape perceptions, foster trust, and ensure alignment with community values, which is very much in line with our board's values and principles, especially around community ownership and making sure that we're doing no harm. We're framing things in a way that solicits feedback that is actionable and doesn't create confusion or reinforce misperceptions about what this work is. So we're excited about that. We also have some other speakers that are still being lined up for, hopefully for the March meeting. And that is, let's see the name. I hope I'm going to pronounce this correctly. It's Amory Vogel from the Oregon Values and Beliefs Center, to share with us some of the most up-to-date information on what Oregonians say they really value when it comes to healthcare, and hoping that some of those insights will be helpful for our communications work as well. And finally, we are moving forward with a small contract for communications that falls within the current budget and authorization. And this will allow us to move forward with a list of community developed resources to support public engagement with the Universal Health Plan Governance Board. The committee started compiling this list of initial needs at our November meeting. And so we're excited to get those things like a frequently asked questions document and a guide for submitting public comment in plain language and hopefully in multiple languages, and a public facing one pager of our values and principles, as well as starting some work on strategic framing that can guide our engagement this summer. Anything that I missed, Amy?
So, and did we get all the names right? I'm looking at Jenny for the consultants and speakers.
Question. Does the committee have any questions for the board or other committees at this point?
I think we had that discussion at our last meeting, so unless there are updates, it was really helpful to hear more about the timeline, so that we can align our work, and be preparing now for that June, potentially June plan that's ready, plan design, that might be ready to take up for public engagement. So I would just say if there's any updates to that timeline, it'd be really helpful for us to know so we can be responsive and supportive.
This, this is just a kind of suggestion, a heads up. In the planned June meeting and public engagement with plan design, I think it might be very helpful, if not important, to also engage the public in terms of how much they are willing or acceptable for the taxations, because it is a big concern in the finance committee.
Yeah, thank you, Dr. Chi. That is something that is going to be a key challenge within our resource constraints in terms of time and funding. The bill really directed and gave us a resource level that was to support the very focused target groups that I think were underrepresented in the feedback that the task force was successful in soliciting. So this is like a phase 2 in a much longer process. There is some mention of broader public engagement, but our resourcing, at least initially, and certainly our timeline constraints do not support a broad public engagement strategy. So I think we'll have to creatively figure out how to partner with external groups, which is one thing that the committee is looking at, as well as what we can do within our resource constraints. And I think that's some of where the communications consultant is going to be helpful to create some documents that'll be helpful for that process. But that is something that I think the committee has really struggled with, because I think all of our values are that we want to do that really broad work, and it's been sobering to look at what what resources would be needed to do that, and also how much time that would take. So, but I appreciate that, and certainly it's something we're thinking about a lot.
I would just add that this is also where we want professional guidance on communication and messaging, especially when we talk about taxing in this current environment. And we want to be very intentional about, how we talk about that.
Has the committee had a chance to talk about the idea of rotating board meetings to different communities? Has that come up at all?
We did talk about that at the last meeting. I think that, I'm trying to recall exactly, Jenny and Michelle, but I think that we kind of wanted to see the timing of our staffing issues before we made any concrete schedule, but kind of align with the June timeframe to kind of start doing some rotating meetings. Is that what you recall, Michelle and Jenny?
There was definitely the conversation about aligning with staff in terms of moving meetings and doing traveling meetings, ensuring that we have enough staff to do it, but also looking at the idea that the board would be able to engage with other entities, say putting together an event with business entities or providers or other people in the location where we are. And we wanted to look forward to when we might have something to engage them on, looking at that either plan design, finance, first draft of maybe what they've brought forward, so that the board can engage more meaningfully with those groups there, instead of having like listening sessions necessarily. But then there would also be the option of having the board do a listening session with the general community as well. But I think the timeline was pushed out until there was something that the board can engage with.
Anything else for re-engagement and communications? Great, thank you. Okay, moving on to finance and revenue.
So we do have a straw proposal, and I'll just summarize, and then we've got Charlie, one of our committee members, on to answer any questions about the details of the straw proposal, because he really authored that, and he's been working on the expenditures summaries. So first, the straw proposal, just as a summary, I suggest or recommends 2023 as the base year. It summarizes the process that we've been using, national health expenditures accounts data to get to as the accounting structure and to incorporate expenditure data from a variety of reliable sources. So that's part of the recommendation. The other part of the recommendation is to use 2030 as the projected year, the model year, for because of the legislative and ballot measure process, it will take some time. So we kind of settled on 2030. So that's our basic recommendation. And if you have questions about the straw proposal, again, I've got Charlie here to help answer those questions. I do want to just, before we go into it, I do want to just give you an update on some other things we're working on. So in contemplation for the consultant to be on board to help us, we're going to take a deeper dive into the taxes. This presentation by Chenwei was really helpful today. It made me think about a few other things we hadn't really discussed in committee. And I think we'd even probably want a short version of that presentation for the committee. I think it would be helpful to them if you're willing to do that, Chenwei. Because I thought, well, let's just send them the slides, but I think the presentation is really helpful to go with the slides, pretty dense, so that'd be great. So we were thinking we would meet again on March 4th. As you know, we've been doing 2 meetings a month, but I discovered I actually can't make it on March 4th. So we're headed to a meeting on March 18th to really do a deeper dive into the taxes. And we're talking about all kinds of things about like how progressive the tax should be, for example, and which taxes we're willing to include. I was thinking it'd be great to have a few scenarios so that we could look at them side by side. For example, a scenario where we would include sales taxes, a scenario where we wouldn't, so we could see what that looks like. So I think that's where we're starting with the goal of having some, I don't know, rough proposals or directions or scenarios for the consultant when they come on in, I don't know, late March or April. So that's what I'm hoping for. I'm not sure if we, of the order of things, whether we should have kind of almost a straw proposal for the consultant to review or some ideas first, or if we should do a straw proposal for the board first. That I'm not sure about, but maybe we could talk about that on March 18th. We also didn't get to the deeper dive on administrative costs yet, so we want to talk about that at that same meeting. We'll probably use about half the meeting for administrative costs and half for the taxes discussion. I believe the committee, including myself, felt that the administrative cost savings estimate was a bit conservative that the task force recommended. So the committee, some of the committee members had an idea of inviting a panel of, let's say retired hospital insurance plan executives to really talk about, to help us get to maybe a more realistic estimate for the administrative cost savings. So we are gathering ideas from our committee members on who to invite. And so we're hoping to have that panel also on March 18th to just have a deeper discussion. Let's see what's on our list of tasks was to review methods of revenue collection that withstand an ERISA challenge. So that's still on the list. Some of our committee members feel like we've exhausted that topic. And I don't know if we have agreement on that. So we're gonna revisit. And then the other thing that's withstanding is how to implement a tax that withstands or avoids, let's say, the kicker. So we still need a legal opinion on that. And I know that it's first going through the legal counsel for the board. And then I don't know, whoever will give us that opinion. So that's still kind of on the docket. Yeah, I think that's where we're going next. We're going to consider so many of these tax options and some new ones again that I hadn't thought of. And with that, I think we'll go back to the straw proposal in case any of you have questions or comments about that proposal. One thing I didn't mention is that we feel like we've spent a lot of time on estimating the expenditures, and we really want to just wrap that up and share what we've learned through this work with the consultant, and so that they can use the information as they're helping us with their estimate. So with that, if you have any questions about or feedback on the straw proposal, then I'd open it up.
So, one, I thought the straw proposal was great. Just one quick comment, I think it's alluded to at the end. I think it's great the group is using the national health expenditures as the baseline and all of that. I just think it's gonna be really important, and you allude to it, to once we have some actuarial consultants, to have some external validation of those.
Exactly.
It's gonna be critical to be certain that we have at least one, if not two, external validators.
Absolutely. Totally agree.
Any other questions about the straw proposal? And again, to summarize, the proposal is to use 2023 as the baseline year. And then the projection forward would be for 2030. And then any expenditure data would need to be reviewed and validated by our consultants. So in the resources needed section, you noted that the finance and revenue consultant will confirm the data and make updates. But yeah, so I guess as long as that is the qualification.
And in the last committee meeting, I asked Charlie if he could do a summary of the data and his methodology, and very clear on the sources of each of the data elements to provide to that consultant.
Does anyone have any questions about the straw proposal? So this is our first one, and just as a reminder, what we're looking for is for the board to approve this as a straw proposal, which basically means we're giving the Finance and Revenue Committee the go-ahead to continue down this path that they're going on. If we would like to make any revisions or qualifications, Bruce's was noted, then now is the time to do that, so that we can send this back to the committee and they can take this as our approval to go ahead down this path. If there's any objections to this, now is the time to raise them so that we save the time and the resources of the committee of going down that path. So if anyone has any reservations or concerns about this, please raise them now. Okay, and then I think we can take a vote to approve this straw proposal with the qualification as mentioned by Bruce that all expenditure numbers need to be validated by revenue consultants.
Helen Belaga,
Do we need a motion? Somebody make a motion for that.
You need a second.
second. Great. Helen Belaga,
Yes.
Sunway Chi,
Yes,
Debbie Diaz,
Yes.
Amy Fellows,
Yes.
Michelle Glass,
Yes.
Rick Goldberg,
Yes.
Judy Richardson,
Yes.
Cheryl Ramirez.
I vote on that?
Yeah.
Yes. Just want to make sure.
Great. Thank you for your work.
Thank you.
Yeah, that's excellent. Okay, any other updates from finance? Okay, great. Then we will move on to plan design.
All right. So on February 6th, we went ahead and had our fourth plan design and expenditures meeting. During the meeting, we had a presentation on eligibility and enrollment that Danielle Ross gave, our policy analyst at OHA. We also had several committee members working outside of our meetings in small work groups on two topics, long-term care and behavioral health. So they did presentations to the committee on each of those. After that, what we did was we had, in order to account for a longer discussion, we had folks self-select into one of 3 rooms in order to further discuss either eligibility and enrollment, long-term care, or behavioral health. After that, we came back together and kind of talked about what was discussed, the report outs. And ultimately, what is happening now, we don't have a straw proposal to present today, but we do have 3 straw proposals in the works that will be discussed at our next meeting, which is going to be on March 6th. So we've got individuals working on those straw proposals along with staff, and then we will have a presentation of those and robust kind of large group discussions on each of those and be able to make any tweaks and hopefully at our next March meeting, come to you with at least 1 and up to 3 straw proposals just based on how those discussions go. We have a really engaged group, and so lots of robust discussions. Because of this, we are pushing forward a bit what our projected next topic was, which was provider reimbursement, just because we're not ready to move on to that. But the plan at the next meeting will be to call for group members who might be interested in also kind of doing the similar thing with the long-term care and behavioral health, where there's a smaller work group in the interim to kind of tee us up for a discussion and ultimately straw proposals. As far as what, the next steps is really just that, just working on those straw proposals, getting them ready to present to the group. We don't have any specific questions at the time for the board or other committees, other than there is just ongoing desire for ultimately actuarial analysis once we have proposals and kind of a direction that we're going. And then there's just some additional, questions that will help kind of refine some of these straw proposals. One that comes to mind specifically with OHP coverage and what is covered. One of the things that was kind of discussed as far as specifically behavioral health was starting with OHP as kind of like a blueprint, but expanding that, or at least most parts of that to all. But really kind of needing to narrow down exactly what is covered versus what isn't covered in the list that was given. So that is ultimately, we'll ultimately have additional resources needed once we have actuaries on board and more of a direction. But ultimately, we are in the works of those straw proposals and then just kind of pushing our timeline a little bit on provider reimbursement. One thing we did talk about was having a specific work group, not just for provider reimbursement as a whole, but also a behavioral health, mental health specific provider reimbursement work group, since that does work a bit differently. Yeah, I think that pretty much quick summary. Helen, if you want to jump in and add anything that that I may have missed.
Yeah, I think we had a really interesting and complicated discussion about long-term care, which is one of the topics the task force also raised, that is an ongoing issue of how do we pay as a community, as a whole state, how do we pay for long-term care? Of course, long-term care is covered under OHP and would continue to be covered under those circumstances if folks meet income requirements for it. But the idea of how the universal health plan will address long-term care is a complex one. It doesn't seem feasible at this juncture for the universal health plan to cover long-term care for all the citizens of Oregon. And so how we would meet that need, either leaving it as the status quo that people would purchase private insurance to cover long-term care if they chose, or else spend on their assets to qualify based on OHP eligibility. Versus setting up some sort of different system similar to what Washington's doing, of instituting some sort of revenue process, either Washington's using a payroll tax, but some sort of revenue process to set up a public option for long-term care that people could have access to. So that was a really interesting discussion, and likely will need a whole lot more work as well to sort out how that would function. other than that, yes, we have a great group and they're very receptive to homework assignments, which we really like. So we have a lot of knowledgeable people on the committee and having them do some background work in between meetings has been incredibly useful and it's a great resource. So I'm hoping that we all use our committees that way. Yeah. Any other questions for Debbie about plan design? Debbie, do you have any sense of how you may need the consultant as they're brought on board? As we said, that's anticipated not to be until closer, probably till April. But I know you've been utilizing our HMA consultants quite a bit for this work. And do you have any particular needs that you can foresee regarding that? Bringing on the new consultant?
I mean, I think the main thing, at least as far as the committee is cost and how this is, I mean, that just seems to be the looming question. And I think we're trying to frame like, coming up with ideas and not letting that fully limit us, but the reality of it is that will be a limiting factor. So I think definitely getting actuarial analysis. I know, depending on what comes of the long-term care, orchestrating with DHS and trying to answer some of those questions if it is going to be kind of pulled out of the plan itself. Those are two that come to mind. I think there are some sooner, I think we're going to I anticipate that there's going to be some questions that come out of eligibility and enrollment as well, that may not need to necessarily wait for consultants, but I think we are going to get some more questions specifically out of that one, just based off where the conversation was at the last meeting.
Yeah, absolutely. And the enhanced behavioral health benefits to getting some cost estimates there would be, yeah, go ahead.
Debbie, this is Amy. I might suggest and connect you if you don't already have somebody, a connection, but Age Plus is doing a lot of policy around elders and looking at different factors, and they might be somebody that you want to bring into the long-term care conversation. It's an organization, a nonprofit, focused on policy.
Thank you, Amy. I appreciate that.
Any other questions, comments for Debbie? Okay, great. Moving on to operations.
Thanks. We're just hitting our stride. We've had 2 meetings. We've had 1 meeting or 2 meetings. Anyway, we're hitting our stride. We are, our first task was to look at public corporation structure. We don't have a straw proposal for you today because we're meeting to finalize that next week, and then we'll bring it to the group. We had a great presentation by SAFE and OHSU, 2 of the state's 3 public corporations. And it was really instructive. SAFE telling us what they wish they had done, and OHSU showing all the things that SAFE wishes that they had done. It was a great discussion, and it really was very technical and, boiled down to in setting up a public corporation, it's important to be excluded from all laws that apply to state agencies and included into all laws that apply to public bodies. So, things like, how state agencies, who they can contract with and things like that, you want more freedom from. As a public body, however, you want to be transparent. And I think, OHSU had really a very thoughtful sort of legal structure. And that's where the recommendation of the committee will come forward. So that's really good. Our next task is we're looking at waivers. And I guess what I would ask this group to affirm today is that we're operating under the assumption that we will need waivers for everything. That we plan on having a true universal health plan. It's going to include Medicare, Medicaid, all the federal programs that we're not envisioning waivers for some things and not for others. And
We agree.
if that, I mean, that's always seemed to me the assumptions we've been going on. Which means, you know, for us as a group, we'll get some background into, you know, what that entails, but there's really not a whole lot of decision-making or recommendations. There may be some strategic questions that will come up, I think, later on in our discussions, but for now, we're just operating under the assumption that we will be needing waivers across the board. So seeing that there's head nodding gives us sort of the ability to move forward. Judy, anything you would add?
That's great.
So, any resource needs that you have from our consultants that they come on board, we have the revenue consultant coming on soon, and then the more broad services consultant. Do you see any?
Yeah, we're gonna need a lot of resources
Yeah.
to add a consultant who can tell us the best operational structure, who can cost all that out. Yeah, we've got some needs coming up, and I'm assuming we'll talk about that as we, in our budget
Yeah.
discussion.
Yeah, okay, excellent. Any other, oh, go ahead, John.
I just have a quick question. This might be something in the future, your committee will discuss is what will be the relationship between this public corporation for the universal healthcare versus the governance board?
Versus the.
Governance board.
Oh, we haven't discussed that, nor is that, I think, on our agenda, but I think, I think the statute has been clear about, the roles of the governing board, but I think that's something we probably can and should clarify. Appreciate that, gentlemen. I mean, we've always said it's a public corporation. Then does that mean there's a new board of the public corporation? I think that's what you're alluding to, and I think that would be a good discussion. And, you know, one that would likely involve legislators as well.
My specific question is, what will be this board relationship
Yeah.
with the public corporation?
Any other questions for Bruce? Okay, great. Thank you all for all of your work with the committees. At this point in the agenda, I'm trying to reserve a little bit of time at this point in all of our agendas for just the board to consider it, having heard now from all board committees, if there's any direction or guidance that we want to give, anything you're noticing from the committee reports, parallels, or hopefully not committees that are working at cross purposes to each other, any comments or observations that you want to put forward now. We have some time for that. Okay, go ahead, John.
This is probably something in a few months later when we begin to discuss the reimbursement system. One of the issues we may want to consider, this is cut across several committees, is assuming when we have the universal health plan implemented, there will be substantial reduction of the administrative cost on the hospital clinic provider side. And how do we use that as a leverage to consider the payment structures? Because before the universal healthcare, there's a significant administrative costs ranging from 10 to more than 50% of their operating costs are administrative. But we will bring that substantially down. So how do we use that information and leverage to design our appropriate level of payment?
Right.
That's why we want to do that deeper dive into administrative costs, because we feel like we can just subtract that from the revenue.
And I would just add that that was a serious discussion amongst the previous task force. Because I think the question is where and how do you set that? Aggressively or conservatively? And I think that's a real strategic question for the board eventually. Because there's no exact answer.
And that may be another straw proposal from Finance and Revenue Committee, I suspect, yeah.
Right.
Mine's kind of an elephant in the room question, and that is who amongst staff, OHA staff or OHA partnered staff or our committees is keeping tabs on the federal situation and the speed at which things are happening, but then it's also, you know, the things that are gonna be held up in courts, but, you know, just like who in the state is really watching that, and are we communicating and keeping in step with them so that as our assumptions might radically change, we are getting that information as soon as possible. Because I haven't heard any of the committees talk about that, and I don't know if any of the OHA analyst staff are doing that or are, you know, engaged with other OHA committees or analysts that are doing.
So I know that, you know, obviously the state's paying attention to that on a number of different levels, certainly the governor and the attorney general, or, you know, the attorney general has set up a whole task force to watch that. So, yeah, our expectation is that as our new executive director comes on board, part of their role would be monitoring with our state partners, how many, federal policy changes are gonna impact our work. Yeah, we're absolutely, okay. Yes.
Yeah.
And, okay.
I just want to quickly echo Emmy's point that I think we as the board, we need probably in a few months, we need to develop kind of contingency plan. Because the way it is moving, they already have clear intention to significantly cut, if not eliminate Medicaid. And Medicare will also be the target. So I think we need to think strategically, what if in the worst scenario, there will be both positive and negative impact. The positive impact will be making the universal healthcare even more necessary if Medicare are starting to cut or eliminated. But the negative impact will be, we will be losing the federal revenue.
Michelle.
Yeah, thanks for this conversation. My question is about whether we want to pause and check back in on our board approved work plan at some point. Now that we have all of our committees set up and running, do we want to take a second look at that work plan and make sure that it still makes sense and is aligned with the work that is happening, or the ways in which we maybe need to pivot or update timelines or shift priorities? At times the conversation, I know we all have a lot to track and there's a lot of committees moving pretty quickly, and taking on large bodies of work, but at times the conversation that we have at the board level feels a little disconnected from the approved work plan. So I'm just curious if we want to maybe schedule a time between now and like June, to check back in, or if we want to ask committees to look at their work plan. Anyway, that was my question.
Yes, it's an excellent segue, because the next point I wanted to bring up was that, yes, so Judy and I have been talking about this exact same thing. We'll be getting a new executive director on board, hopefully very soon. We're bringing on these new high-level consultants. And it's a really excellent time for us to do a deeper evaluation of our strategic direction, our work plan, specifically the tasks that we're assigning to the committees, and assure that that we're on the right track to get the results that we need, and that the committees have what they need to get their work done. So yes, right now, what Judy and I were considering was that our April meeting would be a strategic design sort of rehash, where we would do a thorough review of the work plan and strategic direction. We were thinking that would be good timing for this board to take on that task, and we're working on some details of that. Next month, we're hoping to have a in detail discussion about behavioral health vision. And so that's kind of on our docket for March, but then we were thinking, April would be, a time for us to all look at that. So yes, I would give all of us, not just the committee chairs, but all of us, the task of, looking very closely again at our work plan, and, we would give you some prompts and questions, at the March meeting, to really think through where we're going, where we should be going, and if the tasks that we've outlined so far are the correct ones. So yeah, it's excellent question, Michelle. Yeah, we're on the same page with that. What do people think about the timing of that in terms of April-ish? Does that feel about right in terms of things are happening? Yeah, okay, great. Anyone have concerns about doing it that soon, or? Okay, great. Yes, we're hoping if we have a new ED on board by then, that'll be just perfect timing to kind of get everyone on the same page. And
And
yes,
board member.
thank you, and I forgot, of course, we have a new board member coming on too next month. Mary Lou Henrich will be joining us for our next board meeting. So pending Senate confirmation, I believe she's.
I think she was confirmed on Tuesday.
Okay, great, yes, yes, so our new board member has been confirmed, Mary Lou Henrich, and she will be with us, and so, yes, bringing her on board as well.
Michelle.
Go ahead, Michelle.
I guess one question that came to mind as you were just speaking about that timeline in terms of April, that sounds good to me in terms of the workflow for the committee that I'm involved in. My question is, are there any concerns on the staffing level in terms of the timeline for hiring a new executive director? Do we want that new executive director to be onboarded by that time? Does it matter? Are there any concerns on the staffing level for this timeline?
Thanks for that question, Michelle. I don't believe so. I think that with the way that the hiring process is proceeding right now, it is very likely that we would have a new executive director on board in March, barring something happening in terms of the interview process that we're going through right now. At which time I think you could all discuss moving that back further if you don't have an executive director on board, because I think Helen said it would be something that you did after the new executive director was onboarded. But I think in terms of a March timeline, it's very likely that we would have a new ED by then. And probably enough in advance for that person to also acclimate and be able to participate.
Not a first week task for them. Thanks.
Right, and yeah, I agree with Jenny that if it looks like that's not gonna be feasible or productive, then we certainly could bump it back to May. If we need to, but our hope is to be ready to have that discussion in April. Consistent with all of the work of this board, which is moving very quickly on a short time. Great. Any other comments, thoughts about strategic direction? Okay, I will turn it over to Jenny, who's going to talk about our budget request process.
Sure. So as an update, the DCBS, oh, sorry. As part of the update, I just wanted to let everyone know that DCBS, who houses our budget, did go into their Subways and Means Committee meeting on Monday and Tuesday of this week, where they give the first presentation of the committee, or I'm sorry, of the agency budget, which included our budget. There were no questions specific to our budget. Nothing really pointed out about our budget. It just kind of went through. Not that it went through in terms of a vote. They haven't voted yet. It didn't just go through. But they have gone through the first hurdle, and now that'll go to the full Ways and Means Committee as part of the larger package. So there were no questions or concerns at that point. In terms of looking at our budget in general, one of the conversations that we had was around resources and asking committees to look at their resources. In order to allow committees to consider what resources they might need, we didn't want to give them a budget number because that doesn't really translate for the committees, because there's huge contracts like our UHP services contract, which is of a certain dollar amount, but it's not broken down by committee into dollar amounts given to that committee. It's really broken down in services and what services each committee will receive from each of the contracts. So looking at community engagement and communications, and there's something I want to point out specific to community engagement and communications that is a topic for the board. There is service contracts to support all of the needs of the community engagement and communications tasks. So each task has what support they will receive. Some of it is committee-based, some of it is staff-based. The majority of it is consultant-based, and that consultancy is built into our budget. The one thing that I do want to point out that I think has been a reoccurring topic for the board that hasn't been adequately addressed is the fact that there is a task within community engagement and communications that is for community engagement, broad community engagement around the finance and revenue plan. That is an area where we don't have good consultant support or a good plan around how to do that broad of outreach. And it is something that I think the board may need to discuss in the next strategic planning session in terms of, is there more funding necessary and how broad does that outreach want to go? What is it that the board wants to get back from that outreach? Because most of the work that we've done thus far and the way that the consultant support has been structured is around that targeted engagement of those individuals that are outlined in the bill in terms of getting that feedback from healthcare providers, healthcare insurers, not so much the broader community. And the fact that it's in part of the tasks in the work plan to sort of go out and really look at the community engagement around that finance piece. Like Michelle said, we're doing that by bringing in other groups that have done some work out in the community to ask questions about this. But if we're going to do broad public outreach, it's definitely something that we need to revisit in terms of what those resources look like and what the board wants to achieve with it. You can go to the next slide. And go ahead.
So as you know, Jenny, our committee really coalesced around this notion of citizen juries, as Chenwei mentioned, because we want to get these tax ideas in front of a broad group and several groups beyond the focus groups that Diana was talking about last time. So we'd be very much in favor of funding for this specific purpose.
Anyone else want to comment?
Yes, I echo Cheryl's comment that one of the vital factor whether this plan will succeed or fail is about how community their acceptance in terms of the taxations of whatever finance plan. And so I think as we move along in designing the finance and taxation, we need to have some feedback, some information from the community. What are the range or area of their acceptance? Because that can help us tweak or to direct how we design the finance plan.
There's also, my sense is, we have one committee that hasn't even started yet.
The transition.
Transition committee, and that needs resources. And then the other thing I would say is, I've never had a budget discussion like this without seeing numbers. And I guess to me, that's a little frustrating. If we're going to agree on a budget, I'd love to see a true budget that actually has what the costs are and dollars are. I didn't see that in the slides that we had. Maybe I missed it.
I didn't put it in it's not in the presentation
Yeah.
for this, and it could be, I mean, the budget's sent out to the board. I
guess what I'm saying is I didn't see a budget.
Oh.
I saw a group of slides like this.
Right,
I didn't see what I would consider a budget.
so I can't break down budget by committee necessarily, but we can by service contract. So we have a like the UHP services contract is a large contract. I don't know if I'm allowed to say the amount now that it's closed. I don't think that I am for procurement purposes. But it's a large service contract, and within that contract, there is support for plan design, there's support for operations, transitions, and for finance and revenue.
So,
Right, but there isn't, we just talked about a bunch of things that would require resources. And we haven't.
Yeah.
I'm just totally flummoxed by how we're doing this and would appreciate, I think, a true budget.
Yeah,
We had a budget presentation.
Yeah, so we had talked about having line item budgets and just showing how much, like, dollar amounts that we're spending for staff. And then as a bucket for consultants.
Sure.
Right, so just bucket line items so that we could see those and lay those out.
So I can provide to the board what our full budget is in terms of the entire, because I know the budget is posted. And
Hold on, the budget, the budget that DCBS did doesn't necessarily reflect the budget that we're gonna need.
right,
So we need to come up with a budget with a rationale that has beneath it, here's the dollars we need and here's what they're going for. Right, and we're wasting time because the legislature is going to vote on that soon.
sure, and so in terms of what the budget is for services, if the board wants to break out in terms of each individual task, what
No,
amount?
No,
We just
No.
wanna see a line,
So we
Are
have,
you gonna be able to say how much it's gonna be for citizen juries?
No.
So we're not gonna do that.
well, I'm not saying that we're not gonna do that, I'm saying I can't allocate a dollar amount to what that would be, we would have to.
But we need to, is what
Figure
I'm
it
saying.
out.
That,
we need to figure it out.
that's what
Right.
I'm saying.
And then
If
the
we're
board
gonna
has
have
to decide,
citizen
do you want
involvement-
citizen juries?
What?
If the board wants citizen juries, then we can go and cost out citizen juries.
Right, but that's what I thought we were trying to do in
Yeah.
this process. And I guess I'm just confused because we started a month and a half or two ago and talked about how committees will say what they, what they need and we'll have a budget. So we need to know what a transition plan's gonna cost, what citizen juries will, what enhanced community outreach is gonna be. I don't think we have a true budget yet,
let's
and we
plan,
need one.
yeah, let's plan on doing that at our March meeting, have a more thorough budget discussion with line items.
So in terms of what you would like us, me, whomever's in the seat, to provide at that meeting. I don't know that we can cost out what it would cost to put together a transition plan. Unless we look at what resources are specifically necessary and then look at the market for that. And what resources we would need for that. As it's structured now, it falls into a large service contract that was created to align with the budget that was provided. And I think that I understand what you're saying in that the budget that was provided isn't necessarily the budget that's necessary. And so what does the board need to be asking for? But in terms of what the board needs to be asking for, we have a lot of services within these current contracts that are being either brought on board or negotiated. And we would need to, I believe, cost out each of the items that are currently in that contract.
Yes,
And then cost out what would it would look like to do future services.
yes,
Yeah,
that's what I thought
That's
we
the
were
work we
doing,
need to do.
and I thought we would have today.
I think that is going to take some time. If we're going, if
But
I will say I am going to do that individually, it's gonna take some time to whittle down exactly how much the market cost for all of these services is going to be. And I'm happy to do that going
Michelle,
forward, but that wasn't really, at least how I understood what the conversation was going to be.
Michelle, you have a.
Thank you. I think this is a helpful conversation. To me, there are some ambiguities that are complicating what sounds like it could be straightforward, but I'm not sure that it is. And one of them is decision making. So for example, the community engagement and communications committee looked at what resource needs we would have to do what's in our board approved work plan. A citizen jury is not in our board approved work plan. it's the first time, I mean, we discussed it as a concept when we did our values and principles work, but it's not anywhere, as far as I know, in our board approved work plan. And so there's a process and a decision making that would need to happen at the board level. So I heard it raised today as an idea, but to then have staff work on putting money or putting a proposal together and costing that out before a decision's been made by the board seems haphazard to me, I guess. And the other piece that I'm considering is timeline. We have 18 months before a report is due to the legislature on the work that they tasked us with under the bill. And if we're going to significantly expand the scope of that work, can we, if we don't have a plan until June, then are we going to have time to hire a consultant, decide as a board what type of citizen jury structure we want to create, and then seat that? And like, can we do all of that and have a report ready by next September? I guess like this work that we're engaged in it started before us and it will continue after September of 2026. What is our piece? How do we make clear decisions and then ask staff to cost it out? I guess those are like my process thoughts in this moment.
Go ahead.
So two things. One is we need to find a different word than citizen jury that is a frightening word in the disability community. And so, and I've gotten that feedback from earlier meetings, and I think we did, when we did our values work, come up with another term, but I need to look back at what that was. The other thing is on this task, that doesn't have the resources currently. That's dependent on also having the plan, right? Like we can't go out and talk about what are you willing to pay when they don't know what the what is. So I just want to point that out, right? I mean, I don't think we're gonna go out and have conversations about how do you feel about being taxed when we don't know what.
But they're
What they're-
inevitable.
Yeah. That's all.
So, is it useful to keep going through these for each committee and just talk about what's missing?
So this is the only one that has a missing element. If you can go to the next slide, Katie.
So if I'm understanding this correctly, this is the result of talking with each committee about what the work is to be done and what resources you might need to get it done, right? So that was the conversation that we had with every committee. And as we went through each of the tasks, the issue was, can we identify any work that we feel is really important to be done that is currently not resourced? That was our goal, right? And the only thing you came up with all four committees was this outreach from the finance committee about the revenue structure. Is that right?
That's one other thing.
Yes,
There was one other thing. Well,
that was not included in the original consideration for the contracts that had
Yeah.
been already sourced, I'm sorry, not sourced out, scoped out in terms of the work that we would be bringing in.
was the other thing about communications?
Kind of, well, and I'm forgetting what it was called though, but it was a way for an individual or a business to know how much they would pay depending on.
Right.
Can you help me? And I thought maybe you said, I don't know if I dreamed this, but I thought you said that one of the consultants could help us with that. Or that there was a way to,
A cost calculator.
yes.
So we do not have a cost calculator envisioned by the board as something that the board has talked about creating. There is a healthcare economist who has created a cost
That's what it
calculator,
was, yeah.
who is willing to come and talk with the Finance and Revenue Committee about the structure of the
Yeah.
cost calculator and other expense related ideas.
I knew that came up, but I didn't have it in my
Yes.
notes, yeah, thank
Yes.
you.
That is not a contractor that we are bringing on. That is
Okay,
someone who
that's
has,
someone else.
who is a professor who has volunteered
Got it.
to present.
But the summary of checking in with all the committees is that we currently have the resources we need to meet the tasks as they're outlined, with the exception of the outreach around finance and revenue, and with the exception that Bruce brought up about the transition committee, that we didn't consider that committee and the resources that it might need.
So the transition committee's work plan as it was developed by the board originally, even though the committee hasn't been started, was included in the scope of work for the UHP services contract.
Again, I haven't seen a budget.
Yeah.
And what I had a very brief conversation that went something like this. Here's all the things, we have support for that. I actually got a dollar figure for that, which seemed reasonable. But I don't see a dollar figure in a budget. And I think we are responsible as stewards for saying, if there is X $100,000 to help with operations, putting together what an operational structure of a health plan would be. I'd like to know and be able to follow that and be a good steward of the budget.
Yeah.
I
I agree.
don't understand what is so difficult
Yeah.
about this.
Right, I agree, and we had talked about having that at this meeting, is that possible for March, that we can do that?
So, yes.
Okay, let's do it for.
So I just want to be really clear, is what you're looking for just what the service contract budget is?
I'll sketch out for you.
Okay,
And I'm gonna put X's in where I'd appreciate you would fill in the dollar amount.
okay. Because we can provide the information for all of the different service contracts, all of the different types of service contracts for the staff services, how much that's budgeted at. So all that information is available. It's just that taking each individual task and providing a cost
not
for
what
it
we're
isn't
asking.
something
No,
we've
that's
done.
not-
We're not
Okay.
asking for that.
No,
But it seems
Okay.
like you're asking for something that has been sent out to you every quarter. Like every quarter, the executive director has sent
This
out
one?
the budget with the numbers. So
I
what,
read-
what's different that you're?
I run a nonprofit that has less than $100,000 budget, and I show my board our budget every month. That's all I'm gonna say.
We'll talk about it, we'll come up with a plan for it. Do you want
And
to?
just let me, Katie, I think the difference is, what that is showing the current budget. What we're doing is planning for the next 2 years. We have an opportunity right now with the legislature to get a budget. There's one opportunity, it happens now. And what we're doing is trying to understand what we're going to need from July 1.
Yeah.
2025 through June 30th, 2027. That's very different from taking what we have now and what's being spent.
So I think that's where the disconnect is, because what we're gonna tell, what Jenny is gonna share with you next month is the budget that we have right now.
And it's the budget that goes, so the budget that we have currently is an expenditure amount, right? An
Yes.
expenditure limitation.
Right,
And so that expenditure limitation continues through 2027
I know
with
that,
the current.
but what I'm
sure that
saying
does.
is, I don't think that's enough.
Right,
And so I would like us as a board to be able to go to the legislature and say, we need more money.
So
I
maybe-
think that's totally
To
fair.
Jenny's point then, what does she need to do to prepare for this meeting next month?
That's what I thought we were doing, is preparing a budget for the next 2 years.
Or is that what's already been submitted with the,
That's what is submitted with the DCBS budget. That's not what Bruce is talking about, though. Bruce is talking about beyond current service level, beyond what the budget we currently have through 2027 is. What else might the board need?
but I'm wondering if it's already gone through the first hurdle without us having had this conversation.
It would have been good to have this information for the first hurdle, we don't have it, but there's a second and a third and a fourth hurdle that ends when the legislature ends. And we need to be able to, if you don't ask,
Yep.
it never happens. So we need to be able to ask, and we need to do that in an informed way. We don't have to, we could just say, okay, give us current service level. But that doesn't seem like what we want to do as a board.
So the only question I have, and I understand where you're coming from, Bruce, and the budget that we can provide to you in terms of what that looks like through 2027. The question I do have is, in terms of the board identifying what else they might need beyond what is in the current budget, which is structured as such to spend the allocated funding and contract to a certain number for all of those resources.
We're going, let's put, I don't think this discussion is actually getting us where we need to be.
I agree. Yeah, we'll talk it through and come back with something in March. Okay. Think we can, so our next agenda item is just briefly touching on any board outreach that has been done or that you've been asked to do. Does anyone have anything to report on that? Go ahead, Amy. Oh, did you?
No, next week,
Oh,
I'm not involved, you're right.
Thank you, Chen Wei, for reminding me, talking to the Willamette Valley,
Town hall meeting in Columbus.
Oh.
Thank you.
Great, great.
I encourage my students to participate.
Along with Mary Lou and John Santa.
Oh, nice. And who attends those? The general public or is it?
Yeah, general public.
Okay, cool.
Thank you for reminding me.
And then on, I mentioned it last time, but on March 1st, I was invited by the Eugene Healthcare Coalition that's putting on their second citywide healthcare forum and healthcare to be on the panel, and other panelists include Senator Manning, Representative Lisa Fregala, Eve Gray, who's on the, which committee, Plan Design Committee? Plan Design Committee, and is also the Director of Lake County Health and Human Services, the fire chief, and a hospital staff nurse, and Valdez Bravo from Health and Development. Yeah.
Anyone else? Opportunities to engage, outreach.
The specific day of that town hall meeting is 36th Wednesday from 7 to 8.
Will it be recorded? Or
I don't know whether this will be recorded.
And then, of course, I'd like feedback from both of you about how our current presentation is, if there's anything else that you need from it. I think we have a really standard set of talking points and PowerPoint presentation already laid out with our process and our work. If you need something more than that for your presentations, please reach out to Katie or Jenny or me, and we can have that.
is it something that gets updated after each
Yes.
board meeting? So, okay, so it'll be updated next.
Yes, great. I'll watch for that, which is the next topic. Do we need to update our talking points or presentation based on today's meeting? I'd love to include some information from John Way's presentation in there, and we can talk about that. Anything else that people would like to include as a takeaway from this meeting? Okay, and then in terms of future meeting topics, I already mentioned that next month we're hoping to focus on a behavioral health vision. In April, we're hoping to focus on overall board strategy and our work plan. In terms of engaging all of you with our agenda planning, this is the time where we're open to feedback on what our agendas should include. Certainly we'll have something on budget as well, as that came up. But in addition to those topics, does anyone have topics or issues that you feel this board needs to discuss that we need to include on our agenda in the next couple of meetings? And you brought up the federal landscape. I don't know if that's something we should consider having a more structured discussion about, or just touching base with our state partners on.
I just want to make sure that there's like somebody
Somebody's
on staff or,
Yeah.
that there's a connection to getting the latest information that the state's monitoring.
Absolutely.
Considering how dire the consequences could be, I think it should be a standing agenda.
I do too.
item, but we've been starting to do that in other meetings.
Yes.
I think,
Go ahead, Michelle.
I think that could also be something we would need to consider in, as something we need to touch on in our report back to the legislature. There may be things that were originally envisioned to be part of our scope of work, such as applying for federal waivers, that need to be moved in the timeline in response to certain changes. And that's just one possible example. There may be others, but I think keeping in mind as we get those updates, how that might impact our what context we need to share with the legislature about what we did and did not accomplish and what the rationale for that might be.
Any other agenda items this board would like us to discuss? Future meetings? Okay, great. Please feel free to reach out about those, and I'll turn it over to Judy for public comment.
Thank you, Chair. We have 4 members of the public who have signed up for public comments. 3 online and 1 in person with us. I'll extend an invitation to the person in person to go first. Burns, Pablo.
Am I going over there?
Yes. And there's a little microphone to turn on, please.
Good. Is it morning or afternoon?
Just
Push
hit
the
the-
button.
hit the button. Perfect.
Oh, it's green and everything. So for the record, Dr. Burns Sable, representing the Oregon Chiropractic Association. And given our history of provider non-discrimination language we've gotten into Oregon law, my comments are actually questions, and that is relative to not discriminating against healthcare providers in this proposed universal health plan as it pertains to participation, coverage, and reimbursement. What we've got in Oregon law is currently, so it's my first question is participation. Is it the presumption, the goal of this, of the plan to have it to be an any willing provider provision? In other words, any provider willing to follow the statutes, rules, guidelines, pathways would be allowed on the state's panel? That's question one.
That's outlined in our statute, yes, that any provider who's licensed and in good standing in the state is eligible to participate in the plan. That's in statute, yes.
Great, great. And then coverage, if it's a covered health benefit under the plan and a healthcare provider, not the least of which is a chiropractic physician, provides it, then the state must reimburse them for it. You're not going to say, well, we generally don't pay chiropractic physicians for this or that intervention, that service, even though it's in your scope. If it's in our scope, we provide it. We're going to be reimbursed for it.
Right, I think that's the language. I'm not gonna be able to put it exactly, but it says any licensed provider providing benefits that are available under the plan.
Right.
Will get paid by the plan, yes.
Well, we've got administrative rule relative to the commercial health insurance that really spells it out. So, and then the last piece is reimbursement. And this has been a real contention. That is reimbursing us all for the same covered service. We provide the same service. You pay us all, no matter what the type of provider is, you pay us all the same if it's within our scope, but can vary reimbursement based on quality or performance measures, outcomes. And of course, the idea is to improve quality of care to Oregonians. What say you about that?
Well, so we haven't taken up that issue yet.
Okay.
Our plan design committee will be discussing provider reimbursement strategies, including a quality strategy in coming meetings, but that hasn't been tackled yet. So yes, we're far from a decision or any input on that yet.
Well, that's something that's very, very important to us. So all the quality of the complementary alternative medical providers. So thank you.
Yes, thank you
Thank you.
very much. Do we have Tom Sinek? Sinek.
Hello, I'm going to get started. Okay, thank you so much. Chair Blanca and Vice Chair Richardson, members of the committee. This is Tom Sinsick, retired nurse practitioner. As you heard, DCS budget request, the essential budget item section 3 related to the continued funding of the Universal Health Plan Governance Board was presented to the subcommittee of the Ways and Means. In 2022, Oregonians spoke clearly by adding access to healthcare a fundamental right in the Constitution of Section 47. The Universal Health Care Governance Board is codified in ORS 751. That's the statute. It's the pathway to meeting that constitutional right. We all know the current system is broken. I won't go on to that. That's why you're doing this work. Therefore, it is essential that this board recommend the necessary funding, as you just talked about, to accomplish the work as called for in ORS 7, not the given funding. The current proposed funding and its core adoption was the original dollar amount before you started the work plan, before you had the committees, before you were prepared to actually figure out what you needed. So Each of the committees and the board staff requires staff, technical support, consultants, and processes necessary to complete the work. You all know what that is. ORS 751.11 states, subject to any applicable law, the executive director shall appoint staff as needed for policy analysis and administration support, as needed. The executive director shall contract experts and consultants as necessary to carry out this work. Legislators, multiple legislators, are anxiously waiting to hear what you actually need. They're waiting, they're asking, please send us something so we can respond to you. So this is what the important part of your previous conversation was. Again, a reminder to all of us, Oregonians have a constitutional right to advocate for affordable health care. That community engagement is essential. It needs to be broadly funded. You need to ask for what is necessary to do the work. Thank you very much for your time. Your work is so greatly appreciated.
Thank you, Mr. Smith. Lou Siniger.
Yes, can you see me?
Yeah, thank you.
Hello?
Repeat.
I'm not getting my picture up here, but
It's you.
shall I get started? I can
Yes,
see.
go ahead.
Okay. I want to support what the board is doing. My name's Lou Siniger. I'm a volunteer for HCAO in Lane County. The budget is so tremendously important. How can you approve a budget without a dollar sign? Yeah. Well, I would like to remind the board that the original dollars for this board was not enough. It started out that the board members would be paid, right? But now you're all volunteers, which means that you cannot give full attention. So I want to remind the board that when this comes out, when you succeed in developing a plan, we are going to have powerful forces that will be against that plan, which means that the board has to do an extremely good job of developing a universal plan. You're going to have to pick up every stitch, okay? And so if I was doing it, I would just double what I was given last time, because this is 2 years. You're gonna do it, okay? One last thing I did want to mention is that the resources, how you get the resources for the plan, cannot be subject to the general budget. If it's subject to the general budget, it will be subject to administrative changes, and all kinds of things. So whatever is necessary to do, you have to keep that budget separate and in its own fund from the general budget. Thank you very much for listening to me. I'm sorry I can't see myself. Bye.
Thank you, Mr. Kinney. Lastly, we have Caitlin Kim.
Hello, my name is Caitlin. I'm a fourth year double major in biochemistry and innovation management at Oregon State University's Honors College. I was really just grateful to be able to know that there is a board that is working on some of the initiatives that I've dreamed of from a really early age. I've lived in various states, and I feel like it's such an opportunity and just blessing to be in a state that is actively working towards a lot of the principles I want to work towards as a future healthcare professional. And I know a lot of students at Oregon State feel similarly. So I really wanted to just express support and gratitude to the board for being able to take the initiative on working a lot of these priorities. I really do want to be working in a system where I feel proud to work in, and I feel that I'm giving most of my attention and energy towards supporting, not only advocating for patients, but making sure that our healthcare ecosystem is functioning well. And so I am really just wanting to express support for looking at the logistics of the plan and making sure we have adequate buy-in from the people who will be directly impacted, whether it's the providers, the patients, the healthcare administrators. I think so many people, I've tried to talk a lot to students and professors and doctors that I work with about the board, and a lot of them don't know about it. So I think it would be amazing if we could also continue the efforts for outreach and communication, because I think so many people, if they realize that there is forward progress on this, would be really happy to provide feedback and support. And I think it could really pave the way for a lot of other states to also see that we can make this happen. So thank you again for working on this, and I hope to understand how the budget will continue to develop so we can provide those benefits. Thank you.
Thank you, Caitlin. Good luck in your studies.
Yeah.
Come to the town hall next week.
Next Wednesday.
Do you plan on taking any classes with Dr. Chi?
Not
Oh.
a my student club for spring term. So we're very excited about that.
We highly recommend it.
Great. Does anyone else have any business for the good of the order? Okay, then I think it's Charlie who brought our final thought for the meeting.
Yeah, the final thought, again, come from one of my intellectual mentor, the government, who unfortunately passed away on 2012. And so that's the last book he published, The Health of Nation. And he was one of the rare and the first health economists who devote most of his career into promoting equity. And this was previously unheard of economists focusing on equity. So he also introduced the citizens jury into health policy and health economics. And so this quote from his book, he said, healthcare systems become social institutions under a communitarian gaze. And it asks, what sort of healthcare system or system do we as a community prefer? And that question leads to the next one, that what sort of community would we prefer to live in? And I use his quote and give a concluding comment in 2008 Oregon Health Forum, saying a society's health system reflects the nature of the society.
Thank you very much. Great.
Can we get a volunteer for next month's adjournment?
I'll take it.
Okay. Actually, Danielle, did you want to do it?
Okay, awesome.
happy to, yeah.
Great, Danielle. did it. Okay, excellent. Great, then with that, we are adjourned. Thank you all very much for coming.
Oh, if anyone else has iPad issues, please discuss.
Yeah, I mean, that is
Okay,
coming.
okay,
Yeah.
yeah, okay.
Yeah.
What is it?